Good evening, all. Welcome to this wonderful topic that I know so many of you are going to find helpful. I'm joined again by Dr. Harry Karpouzis, who is the Medical Director of Pelargos IVF in Athens, Greece. And we're going to be talking about the topic of conceiving over 40. How many fertility treatment cycles is it likely to take in order to have a successful pregnancy? So this event is in association with European Fertility Society and My IVF Answers. And as always, please note this webinar will be recorded, but it is totally anonymous. So feel free to post your questions in the box, which we will get to later. So I know we're going to have so much to talk about this evening. As you know, when you're talking about IVF at any time, it is a huge investment for people, and particularly for those who maybe aren't entitled to government-funded cycles, which in Ireland is an issue. If you're over 41, you can't avail of it. So it's even more important to get the preparation right and minimize the amount of treatment cycles that you might need in order to have a successful pregnancy. So let's start with the basics of maybe what would you typically recommend in terms of a timeline for preparation, and would this be different if a woman was 40 or if she was 44, for example?
Okay. First of all, hello to everybody, and nice to see you again, Jessica, after Dublin Fertility Show. I'm very happy that you are presenting this webinar. And it's a very interesting topic indeed. Now, regarding your question, I mean, usually we know that in ages more than 40, we have two problems. One of the problem is the number of the eggs that usually is getting lower. And one of the problems is the quality of the eggs, the main issue, which depends especially in one factor, and this factor is age. So there are things in women more than 40 that we can do to prepare. For example, multivitamins. Of course, any person needs vitamin D, and we need to check the levels before. Any person needs folic acid, but women that are more than 40 might need antioxidants and anti-inflammatory vitamins and supplements more often and in a bigger degree than women that are not less than 40 and they are not poor responders. I mean, nowadays we have, at least at Pelargos IVF, we have included in our protocols for poor responders and more than 40 NMN. We have included NAC.
Or NAC, some people call it. NAC,
yeah. It's the Greek way of saying it.
Yeah, NAC. Just in case people are confused.
We have included, of course, coenzyme Q10 that has plenty of data behind it. All these supplements can work in a anti-inflammatory and in antioxidant way as well, improving possibly the quality of the eggs without really being miraculous medication. Now, as far as it regards pre-treatments as well, many times it is important to have a coordinate growth of the follicles. So in order to have an estrogen priming, either with a combined pill or with estrogen priming, is quite important sometimes in people more than 40, especially women that are coming from abroad. They need to schedule the treatment, and sometimes the periods are not very regular, so this is more important. We prefer, depending on the case, either the estrogen priming or the combined pill, but the combined pill, it's very important to start the stimulation about 5-6 days after the last pill. So that
if I may rewind just a tiny bit, just for people who maybe aren't familiar with these protocols and might be feeling a bit overwhelmed, because we've gone from the antioxidants, the estrogen priming, to the pill. Let's break those down into, because obviously there's the estrogen priming, there's testosterone priming, there's obviously using the pill, longer protocol. Maybe let's delve into those in terms of what person, because there's over 40, but there's over 40 with caveats. So there's over 40 with PCOS, or there's over 40 with endometriosis, or over 40 with definitely premature ovarian insufficiency, even though you'd expect it at that age. So what person would you be looking at for those protocols in terms of preparation, let's say?
We are talking now about how we schedule a treatment. We are talking about estrogen priming and combined pill, or we are talking about the protocols themselves?
Well, more about the lead up, because of course, when you're doing the actual stimulation, I get that for the timing of the treatment, but some people just aren't actually familiar with what priming means, is what I was saying. So
Yeah.
maybe if we can explain the purpose of it, like why you
Mhm.
would do the priming and how it can be beneficial
Yeah,
for over 40.
of course, you're
Yeah.
right. So, I mean, priming works actually for one reason. For when someone's starting the stimulation, many times what we have noticed, especially with women that are poor responders, is that sometimes we have a bit of discordant growth. When we know that from previous protocols, and when we have seen that the growth of the follicles is discordant, which means that some follicles grow bigger and others are smaller, and we have a discrepancy between the size of the follicles, which leads sometimes to immature eggs. We prefer to do estrogen priming, which means give some estrogen either in comparison with progesterone as well, which is the combined pill, or only estrogen, in order to make it a bit more coordinate to growth the follicles at the time of the stimulation. And also, this plays a role as a scheduling as well. People might want to book the tickets in advance, might want to be in Greece, for example, on the first day of the period, and they might not have a regular period. So it's a way of scheduling as well. Combined pill and estrogen priming have more or less the same data behind creating coordinate growth. The problem is that sometimes with the combined pill, the contraceptive pill, it might downregulate a bit the ovaries and make it a bit more difficult to grow the follicles. So in women that are very poor responders, we prefer to avoid that. Or if we use it, we prefer to start the stimulation at least 5-6 days after the last pill. Combined pill is important as well for some women that are endometriosis patients to suppress actually the endometriosis without really downregulating the ovaries a lot. And especially if they are not very poor ovarian responders, it's a very nice way of scheduling and together suppressing the disease before you start the stimulation. With polycystic ovaries as well, usually these women are women that have good ovarian reserve. So you are not afraid a lot of suppressing the ovaries, but you need to schedule the treatment, and especially when we talk with medical tourism. So combined pill is very important in this situation as well. Now, there are other things as well. For poor responders, DHEA. We know all about DHEA. It doesn't have very conclusive evidence behind it, but in some special category that they are low in DHEA, we might give it for poor responders. Now, because you talked about testosterone priming before, you want me
Yes.
to talk about that as well?
We can throw that. I might just backtrack for a second to the DHA, just for
Yeah.
anyone who isn't aware, because we were talking a lot about the vitamins and antioxidants, which we can go back over too, because I'm sure there'll be questions on that. But dihydroepiandrosterone, it's like a mother hormone, and you make other hormones from it. So we know from the research that levels do tend to decline as we get older, and that's why being given a prescription of DHA can actually be beneficial in some cases if your DHA and testosterone, your androgen hormones, are actually low. Because you're absolutely right. I've seen this so often, less frequently now, thankfully, but going back a number of years when it became popular, it was in the research that DHEA can boost the number of good quality eggs in advance of IVF treatment, that everybody was on it. But I was seeing disasters because I was seeing people with DHEA of like 75 milligrams, even 100 milligrams, and their testosterone shot through the roof. And they were having problems with essentially PCOS type symptoms. So very important, as you were saying, just make sure if you're looking at that, that you're being properly monitored and you're seeing somebody like yourself, you know, to make sure that you're actually taking the right dosage and that you're not going too crazy either way.
Of course. Yeah, you're right.
Yeah. So back to the testosterone priming, because so people can understand that side of things too.
Testosterone priming, there are some protocols, special protocols in women that are poor responders that they have some good evidence and some good data behind. I mean, in some categories of women, we try to actually increase the androgen inside the follicular fluid as much as possible, because this might be helping in the follicular recruitment, in recruiting more follicles, and the more follicles you recruit, the more eggs you might be able to get through the stimulation with the hormones, of course. So, I mean, in some of the protocols, and not all of the protocols, we can give the DHEA that we said, we can give the letrozole, which is a medication also that actually kind of one of the ways that it works is increasing the estrogen if you use it in advance. And we have some protocols that we are using as well, testogel, at least in Greece.
Yeah, they use that here too.
Yeah. As a priming, actually, before we start the stimulation the previous month, together with a combined pill or not, depending on the situation. And all these things, the whole job that they are doing is trying to increase the androgen and increase the follicular recruitment, actually, so that you can try and get 1, 2, 3 more follicles.
Because going back to what you were saying about the discordance between the development of the eggs, of course, if someone's over 40 and typically might get fewer eggs, what we're referring to there is the last thing you want is to have 2 eggs flying ahead, and then there's 1 or 2 behind, and then there's another one behind that. You're trying to get a batch of eggs, typically, isn't it, in the 16 to 20 millimeter range. You want them all together as a group so that you can maximize your odds of success by getting all of those eggs. So that's why the type of protocol is, of course, so important, and why it has to be individualized and nuanced to the person. Because I think so often, I mean, what we're discussing here is actually stuff that is to do with the lab and to do with your consultant and who you're dealing with to maximize your odds of success. It's a different topic to just your age, because of course your age isn't going to change, but what can change is your protocol and how much due diligence is being done to make sure that you get the best odds of success. So I think that's a really important thing to talk about. So following on from that, there was something that occurred to me earlier that I thought would be important to discuss, which is for someone who's dealing with, let's say, secondary or tertiary fertility issues. So they're trying for a second or third child. They maybe have a 3-year-old, let's say, and they've been struggling to conceive again. Maybe they conceived with IVF on their first, maybe it was non-assisted, but either or, they have the precedent of having had a healthy pregnancy within the last 5 years. Would you be putting them in a different category to someone who's trying to conceive for the first time over 40? Because I think many people I speak to, it's like as soon as they hit their 40th birthday, they think that's it, game over, nothing's going to work now. But, I would imagine that you see differences in those 2 categories of women.
Yeah, listen, when someone, if we compare, if we take all the IVFs that are successful in the age group of 40 to 46, the truth is that there is a very big difference between people that had children before and primary subfertility. So the women that have children before get in a way easier pregnant in this age group, which it's not actually most probably explained only by the quality of the eggs, because the quality of the eggs, I'm not sure that we can somehow explain that it depends on if someone has got pregnant before or not. But there is not only the quality of the eggs, there are other factors as well. And the implantation window, the endometrium, all these factors that accept an embryo may play a role. And it's not only the eggs what achieves an implantation. So in a way, it's quite normal if someone has achieved a pregnancy before, has a tested endometrium. So if you compare women of the same age, statistically, the statistic would be higher. So I think that the explanation is that.
Yes, correct. And something you said there just made me think that maybe it might be helpful to people, given we're talking about how many cycles they might need. What would you see? You mentioned that sort of 40 to 46 bracket. The oldest I ever saw actually with her own eggs was going up to 47. But in terms of the success rates, what would you see? Because I would see kind of, negligible difference within like the 40 to 43, then 43 to 45, you start to see a shift. So what would you see in your clinic in terms of outcomes, depending on which end of that bracket they are in age-wise?
Well, 40 to 42 is doable. I mean, every case is different, okay?
Yeah,
but we have a lot of pregnancies between 40 to 42. Of course, it's different when someone is 40 to 42 and has an AMH of 0.2 with like 2 follicles only. And it
Precisely.
is different when someone is a polycystic ovary person with 40 to 42. Okay, because in a way, polycystic ovaries work nicely in this age group. They have
Yeah,
more eggs.
it
I mean,
helps.
we have something which is quite clear from the research, and this has no doubts that the more eggs we get, the more we increase the chances of implantation in this
Yeah.
age group. So, I mean, definitely 42 to 44, it's getting much more difficult. And after 44, it is getting very much difficult. Okay.
Yes. Yeah, I would have seen the same.
So,
Yeah.
now, of course, we need to think this a bit differently. I mean, a person that is 41 and has an AMH of 0.2, if you compare it with a person that is 43 and has an AMH of 1.5 and like 15 follicles, maybe the difference is not big and maybe it will work in favor of the person of 43 sometimes. It's a matter of eggs collected. And we have evidence of that and we have data about that. So, for example, we
Absolutely.
know that in 40 to 41, it's about 10 to 12 eggs. 41 to 42, it's about 12 to 15. In order to
That
have
are needed.
order to have one of these to be chromosomically normal. Okay, you understand
Right.
that people are getting like 12 eggs, 15 eggs in the age of 40, 42, and one of them, it's the average of being chromosomically normal. And this, to the age group of 43, 44 and more, might go to 20 or 30. And you understand that it is very difficult with one go to get all
That
this
many.
number of eggs. So the answer to the question of our topic, how many cycles of IVF someone needs in order to get pregnant, it depends on the number of eggs that they can get in each go.
Precisely. On which note then, because I know we'd been talking about this the last time when we were talking about unexplained infertility, so feel free to check out that talk, it was great, is would you then be recommending in every case over 40 that they do genetic testing of embryos so they can identify, did we catch the good egg or do we need to be keeping going? Or what would your recommendations be on that?
Listen, generally, I love PGTA. I like it. I think it shows to people what is the problem. When
Yeah.
someone fails without PGTA, is starting thinking, what is the problem? Is it my endometrium? Is it something else? Is it the embryo? The answer, most of the times, it's very evident. Okay, it's very, very clear, and it is the chromosomes. So I like PGTA. When it is done in appropriate laboratories, it has minimum risks. When you have genetic counseling, whatever the answer of the PGTA is, you can explain it and you can consult it to the patient and can make an informed decision. It gives you always the answer on what is the problem. It reduces the risk of miscarriage. It selects embryos. If someone can afford it, the answer is that yes. In this age group, I would say that yes, we need to do PGTA.
Yeah, and it's not an easy one. I just brought that up because I was thinking of past client who was 42 at the time going through. She had PCOS, so she got 7 embryos at day 5, which sounds amazing, right? To anyone who's watching this, they might think, "Oh, that's wonderful," and it is. But the odds of them all being chromosomally healthy is very slim. And at that time, sadly, she wasn't offered the PGTA. Well, back then it was PGTS or PGS. And she ended up thawing the embryos to biopsy and refreeze because thankfully, having done that, she did find the golden embryo and it worked out of the 7. So just to be really aware of that. Now, on the flip side as well, of course, if someone is going through it and they only have 1 embryo, and they're maybe thinking to themselves, well, look, no matter what, I'm going to give that embryo a chance. You know, we want to go ahead. We want to take that risk. Fine. Of course, you can do that because, yes, there is cost involved. But it's just really important to understand how it can be of assistance to you, if it's feasible, if it's financially, appropriate in your case to consider doing it. Because I have had cases where they've only had 1 or 2 embryos and they had them analyzed and they could see there was a very specific chromosomal abnormality. They were able to tell them practically at what week gestation they might miscarry, or have the pregnancy continue and have to look at termination for medical reasons. So it is very important in this age category over 40 to consider that. And the other thing on that note, because you touched on it earlier, but I think it would be worth going into it in a bit more detail, is the fact that it's not just about the egg. And typically, from what I've seen, Although I had clients earlier today who where the woman was 40 and the partner was a good deal younger. But typically when you're dealing with someone who's 40 and above, their partner's around the same age or older. And we know from the research that age affects the sperm quality too. So is that something that you would be advising people to look at, so they don't have the endless conversation of it's just about you and your eggs and your age, that there's obviously, you know, two people involved, or at least two sets of DNA?
As I said, it's mainly the egg, but it is not only the egg. It can be the endometrium, it can be the immunology, and of course, it can be the sperm as well. Now, the good thing behind the sperm is that usually we are talking about some millions of sperm, even if the sperm is not good. So we have sperm selection techniques, we have tests like DNA fragmentation, like oxidation. We have ways of looking at the microscope and selecting the sperm that looks better. In the eggs, we don't have this luxury. We go with the eggs that we have. So the sperm factor is always important, especially when the paternal age is higher. We need to take that into consideration. We need to analyze about DNA fragmentation and oxidation. I mean, with us now, we are checking oxidation for everybody.
Brilliant.
And we select sperma with techniques like Zymot, like Max.
Let's explain those a bit to people who maybe are unfamiliar with microfluidity, etc. So just break down. So, because essentially these techniques are, you're trying to get the best sperm from the bad batch, let's say, if the sperm quality is an issue.
Exactly, yes. Yeah, there are different techniques, I mean, to make it very simple, that actually selects the sperma without the oxidation, without the DNA fragmentation. One of them is called magnetic resonance. The other one works in a different way. But what they do, both of the techniques, is that they try to select the sperma that is healthier, which you cannot always see it only in the microscope. In the microscope, you can see the morphology, the motility, but it's a way of selecting that. You can never see the DNA inside in one way or the other, but by selecting and by applying these techniques, especially in people that we know that they have DNA fragmentation, that we know that they have oxidation, is very important. Also, one of the things that I wanted to say here is I see people and men, I mean, they go through the sperm analysis, and the sperm analysis is a bit, not good. I mean, the motility
Basic.
not good.
All right, yeah.
So everybody is like, okay, take antioxidants. I have seen many times doing the opposite thing. You know, there are a lot of people that take, for example, antidepressants. And for men that take antidepressants, this can cause reduction rather than oxidation in the sperm. So if you don't check the oxidation and the DNA fragmentation initially, and you start taking antioxidants like that, I have seen it happening that many people are coming at the time of the egg collection and they give sperma. And instead of having oxidating sperma, they have a reductive sperm. And you know, reductive sperm is even worse. It doesn't have fertilization potential. So you need to check, you need to take your antioxidants, you need to do your lifestyle modifications, you need to improve the sperma. You can check the sperm and select the sperm with sperm selection techniques, but always you take into consideration the male factor as well, as you said. Yeah.
Absolutely. And just what you said there about the antioxidants, explain something there for people, because I know how frustrating it can be. And often people read something online and they think they're doing the best thing. But one thing I would definitely recommend that people are very careful with is avoiding taking high doses of one single antioxidant, because put simply, they work like a relay team. So if you have really high levels of vitamin C or really high levels of vitamin E, it doesn't work on its own. It usually is passing on the free radicals to another antioxidant. So the research has actually shown if you're taking lower amounts, but all working in concert together, so you have a number of antioxidants working together in smaller amounts, that can be actually much more effective than high doses where it can oxidize. And you essentially then have the antioxidant contributing to the problem, which is the last thing you want. So that's exactly what you were saying there. But just, I think people aren't aware of that. And sometimes they just go and order whatever fertility nutrient formula they see. And I empathize, it's hard, but that's definitely something to be watchful for. So on that note, because we talked about the sperm, and I think we do need to go back to the internal environment, which is obviously massively important. I mean, I was speaking to clients yesterday who had 2 euploid embryos not working out for them, and they've 2 left. So clearly the internal environment matters. So on that note, if someone is doing all they can to prepare and take care of themselves from the point of view of egg quality, what are the things that you would be most keen to rule out with the internal environment so that we can reduce the amount of treatment cycles they might need over 40 to have success?
Jessica, try to, sorry, again, I need to understand
No problem,
exactly
no problem.
the
So
question.
with the internal environment, because you touched on, you mentioned immune and, you know, blood clotting and microbiome. What are the things that you're going to really want to tick off the list before someone proceeds with certainly a transfer, whatever about retrieval, over 40 so that they have the best chance of success?
I understand, yes. I mean, especially if we do PGTA, you know, the embryos that we are getting are very, very precious embryos in this age. Okay, so what I say, and might be only one, for example, okay? So what I say to people is that this is a very precious embryo, and we need to check things before we put it back. You know, usually, I mean, to do a hysteroscopy is something that might give you some information, and all the people do it. There are other things. It's about chronic infections, and you need to take it as well from the history. Does this person has miscarriages before, DNCs, previous pregnancies, maybe? All these things trigger a chronic infection. Endometriosis is a factor that affects in many different ways. What will be the protocol of transferring the embryo? If we have mild endometriosis, we need to give GnRH agonists to suppress the disease as much as possible. Adenomyosis, very difficult disease. We have some new data, again, about downregulation and some new data about letrozole that I was talking before that can help actually reducing the estrogen as much as possible, because this is a disease that is related to estrogen and might help in the chances of implantation. Then, okay, there are other things more rare, like, for example, immunology and things like that. But we don't put all the people into these tests, to be honest with you.
Yes.
We might have a relevant history as well of miscarriages, of recurrent implantation failures. If we have a history like that, it's very important to check immunology. And I have talked before in previous webinars about how we do that, because this needs to be personalized as well.
Yeah, I'm delighted to hear you say that and use those words about how precious an embryo is that is being genetically tested over 40. Those don't come around every cycle. You know, it's something that I think I've seen many times. People just being told to just move on to FET. And I think for those, particularly the over 40 category, and if they have background health conditions like you described, so if there's a history of adenomyosis in particular and endometriosis, that there's two phases. You know, phase one is really seeing what can we get, like what can you do in terms of getting good eggs and embryos. But phase two is, okay, now how do we prepare before we put the embryo back in? And I think that distinction isn't sometimes made for people. If they don't know, they might think that, oh, we have to just do fresh, unless doing genetic testing. But I've seen, of course, cases where they still elect to do a frozen transfer, even if they're not doing genetic testing of the blastocysts, because that might actually be more appropriate in their case because of the hormone levels and being able to better manage the internal environment, or having a non-medicated versus medicated FET. So just for anybody watching is a bit unsure, just be very aware that your first stage is just get those good embryos. That's your number one focus. Stage two is, okay, let's make sure that it actually works out with the internal environment. I think that's so important. So anything else I noted here in my own questions? No, I think I'm going to move to the list here because there's quite a few questions coming in now. So I want to make sure that we can cover them all. So I'm just going to go to this one here first. Okay, so you should be able to see that there now. So my doctor said I have to calculate around 3 cycles of IVF in order to have success. They love the law of 3. What would you say to that, Harry? Is that what you would be recommending or not?
Yeah, listen, in the age group of 40 plus, the truth is that 3 rounds of IVF, it's not something that it is rare. I mean, usually it is between 3 to 6 rounds of IVF, but as I said before, it depends on other factors. It depends on how many follicles this woman has, what is her AMH, and how many eggs she will be able to get in one go. Okay, so the more eggs, the better, we said before. And if we can get a big number of eggs in one go, might be lucky. If the number is impossible to get it in one go, might need to be persistent.
Yes.
How much persistent? I mean, it's a very difficult question to answer, and it has a big personal element inside as well.
It does, yeah. It's not just the law of three. They used to always say that 3 IUIs, 3 IVF, but it's much more nuanced than that. So I think you're absolutely right. It has to be individualized. Next one here. So what are your thoughts on estrogen priming with Progenova 6 milligrams a day in divided doses starting on day 21 until the period? I'm looking into this, hoping it might encourage a few more follicles to grow. I usually make about 2 to 3 follicles with stimulation. I'm 45 with an AMH of 2.4 PMOLs. That's important to state because AMH comes in different measurements depending on where you are. So thank you. What would you say to Belinda?
Yeah, it's a nice priming technique. We use almost the same. This is the way that you do priming if you start only with estrogen. To be honest with you, with that low AMH, if scheduling is easy to be achieved, estrogen priming in comparison to the contraceptive pill might be more relevant. Estrogen priming, it's not actually that creates new follicles. It's more that it makes them more coordinated and
to grow together. Yeah, so you can have a better outcome. Someone else here. Let's get this one to display. There we go. Should I still take a vitamin D supplement if I have low LADs, so lymphocyte antibody detection, and DQ alpha match, the DQ alpha, or will it boost my immune system too much? 41 years old, trying to conceive for 5.5 years, have never had a positive pregnancy test. That's really rough. I'm sorry to hear that.
Yeah, check the vitamin D. If the vitamin D is insufficient, it wouldn't really play a role in your immune system. The opposite, I would say.
Yeah, no, I would agree with that, definitely, because, of course, if there's any background issues going on, anything that would affect your parathyroid gland and calcium levels, okay, you might need to be careful with vitamin D. But generally speaking, from the clients I've seen as well, I wouldn't see that be a problem, particularly for LAD and DQ alpha. You just want your vitamin D in that nice solid 100 to 150 nanomole range, certainly, from what I would have seen. So let's get back to us there. Let's look over to the next question. Okay. Is it possible to have successful IVF with own eggs with FSH of 80 and estradiol 33? I'm 47 and recently had stem cell ovarian rejuvenation with PRP. That's platelet reduced plasma for anyone who's unaware. Is there anything I can do to decrease my FSH level? That is tough. I'm sorry to hear that, Dina.
Listen, in the age of 47, I have seen a live birth in the last 10 years of my practice.
Yeah.
Through IVF.
Yeah.
With an FSH of 80, it's actually a woman that is menopausal. I mean, the decision to go to egg donation, it's a very personal decision, and we cannot push people in doing it or anything like that. But on the other hand, we need to be honest, I think, because people are spending money and time in treatments, and the decision in the end is yours. But I need to say that with this clinical history of FSH of 80 after stem cells, PRP in the age of 47, the chances of success of IVF with own eggs are very close to zero.
Yeah, it's very tough. And look, I know how hard this decision is for anybody. And it is important that it's as important to have the discussion about when to draw the line in the sand as it is about, you know, how much you keep going, keep trying. And I think that's something that's a big issue actually within the fertility industry, is people feeling like they're failing if they're not trying hard enough, if they're not continuing to just keep going, keep going, keep going. So it is very important to work with the information in front of you and, you know, listen to everything you're offered by your caregivers.
It's you know, I'm not trying to disappoint people or anything like that. But you know, I think that I need to be honest when I'm doing these consultations. Okay, stem cells are experimental treatments. PRP, it's experimental treatment that has been used more. I mean, the truth is that PRP cannot be associated, or stem cells yet, with increase in the pregnancy rates. The truth is that we don't know if it is associated with increase in the quality. The truth is that might be associated with a bit of reduce in the hormones, in about 80% in our data, because we are doing it as well. But in order to get a bit of more eggs, in order to get a bit of more follicles, this is not the only issue. This is a quality issue as well in the age of 47 with an FSH of 80. So things are very, very difficult. It's your right to try it. I understand how much you want it, and you can keep pushing it. There are not many other things apart from stem cells and PRP that you can try to produce a period and get into a normal cycle. But even if you get a better FSH, even if you have a normal cycle, from there to get to a live birth in the age of 47, it's a very long distance. And you need to know that before you keep trying it.
Precisely. It's very difficult. And that's why, like I was saying, have all the information so you can make a decision on next steps, you know, without feeling, because typically, you know, if someone's doing the PRP and stem treatment, if it's going to help, you will have seen some effect on the bloods. So if the bloods haven't changed at all, then it's probably an indication that it may not be helping you. So just to be mindful of that. So I'm sorry to hear what you're going through. Next one here that someone asked. My husband and I have been taking NAC or NAC for the last few months to help with oxidation. But should I stop taking it when I start stimming ready for a collection? I have read it can change hormone levels.
Like DHEA, it's the same question. I mean, I would say no. I mean, I say to people to keep taking it during the stimulation as well. It wouldn't make a very big difference after the stimulation, because the follicular recruitment and everything has already been achieved, and then the hormones play a role. I continue it.
I would agree. Certainly in the research, 600 milligrams has been used in a lot of the studies.
It's the dose as well, yeah.
Yeah, the dosage as well, because we do know like NAC can help clearance of drugs through the liver, but you normally need to be hitting 12 to 1500 milligrams at least. And even at that, you know, most people wouldn't be doing it. So yeah, generally speaking, I would agree. I haven't seen any problems with people taking it during stimulation, and indeed while they're pregnant, because it's been linked to lower miscarriage rates as well. So there's a lot to consider there too. Another one here. This is kind of following in a similar theme to what we were talking about. I heard of a process called oocyte rejuvenation in the Philippines, a reproductive technique that involves transferring the nuclear DNA from a fertilized egg into a donor egg that has its own nuclear material removed. In this way, the mitochondria issue of an older lady's eggs can be replaced with a younger egg donors. Is it a safe procedure, or will the embryo have issues? So we're talking about the spindle transfer and all that.
Yeah, exactly. It's something that we were doing it at our collaborating, laboratory Institute of Life that we collaborate with in Greece. We were the first that we were doing a study, actually. Of course, in this study, it was in a trial study. It included only women less than 40 years old. They were achieved live births and pregnancies, but keep in mind that we were putting into this study women that had very poor ovarian reserve or perimenopausal that were less than 40, not more than 40. Yeah. We haven't got the permission, at least us from the national authority, to sell it, to give it in a non-trial option. It's experimental. It might help. We cannot really offer this procedure.
Yeah, it's not something that's, shall we say, standardized in all clinics. So that is something to be mindful of for sure. Now, this is an important question for those in this category. When should I call it quits? I have done 10 cycles between the ages of 44 to 46, AMH of 3.6, antral follicle count of 8, no known PCOS. My cumulative outcomes have been, wow, this is extraordinary, 139 eggs, 92 fertilized, 3 aneuploid blastocysts, 4 untested, 18 failed day 3 transfers, and 22 frozen day 3 embryos still pending. My last cycle last month, I got 19 mature eggs, 16 fertilized, and 6 fresh transfers but they didn't work out. They failed. My doctor says, despite getting enough fertilized eggs, it's time for me to stop with the retrievals. Do you agree? Wow, that's a crazy number of eggs.
It's impressive, yes.
Yeah.
Okay, so let me go through everything.
Because she's referring to stopping retrievals as opposed to stopping transfers, from my understanding of the question.
Yeah, so how many embryos we have right now? We have
well, she said
22 frozen day 3 embryos.
Yeah,
Do we
22
have
frozen day
any
3.
euploid embryo? Do we
Well,
have any?
four untested blastocysts. So I'm not sure how there could be 3 aneuploid, 4 untested. So maybe they were created on a cycle where they weren't offering PGTA or something.
Yes,
Yeah.
yes. Well, the number of blastocysts of day 3 embryos that you have is good. You are now 40. How old now? 46.
Between 44 and 46, so she must be 46 now. So yeah. I mean, would you maybe thaw the day 3 embryos to grow to day 5 to see how many blastocysts you get? Because 22 is a lot.
Yeah, we could. She could do that. Yeah, I'm just wondering why this age group we didn't leave all these embryos to grow to day 5 and just check. I mean, because the number of eggs that she has achieved in total, it's an incredible number.
It's
And,
extraordinary.
even in the age of 44 to 46, the euploidy rate, in this age group is in the rates of only like 1 to 2%. But 1 to 2% in the in all these embryos might give you some chances.
Exactly.
So the truth is, you can try it. You can try it to see if one of these embryos will work. I mean, it's a difficult question because you still produce embryos. I mean, at least if you were doing some more egg collections or anything like that, I mean, I don't understand the reason of why not checking the embryos to know when to stop. Because if you had checked all these embryos, you would know that you have 1 or 2 or 3 euploid embryos, so you would say, I can stop.
Exactly. And especially, like, usually I would see, and you can obviously confirm what you guys would do, but usually when they say to you, to transfer day 3 or freeze them at day 3 is because they're concerned that they won't develop to day 5 because you've so few of them. So they're trying to maximize your odds. But when you've 22, let them keep going and see what you get at day 5 or day 6. It does seem odd. So maybe that's a question for the clinic that she's dealing with, I would say. Another one here, this is, I think, in the secondary fertility struggles category. I have a 3.5-year-old. I was able to get pregnant naturally, non-assisted, when I started trying for our second, but had 3 miscarriages. Now I'm struggling to even get pregnant and I'm about to turn 40. Should I try IVF? I had my AMH tested 2 years ago and it was 3.5 pmols. Also found to have low LAD as a possible cause of my miscarriages. So should this woman consider IVF as opposed to...
I would say as soon as possible, actually. Yes, you need to jump to the next stage, and because of your miscarriages as well, I would, if you manage to reach with this AMH to have like a couple of blastocysts or more, also because of the miscarriages, it's a nice reason of checking the embryos as well with PGTA, because recurrent miscarriages is one of the very clear reasons of PGTA. So yes, I would say that you needed to jump to IVF as soon as possible because things will be getting more difficult as you grow more.
Yeah, no, I would completely agree. It's because it's as well the heartbreak, like how many pregnancy losses to go through, and then wondering, is it the egg quality and the embryo quality, or is it going back to the LAD and what's going on with the internal environment?
Exactly.
It'll give you answers. So yeah, I totally agree. So another one here in the older category too. So I'm 47.2 years old. Egg retrieval in January, retrieved 12, 9 mature using ICSI, transferred 3 day 3. So 2 8-cell, 1 7-cell with some fragmentation. The transfer was unsuccessful. My spouse has low motility, morphology and quantity, and the doctor wants to use Zymot next time. Do you think it will help?
Yeah,
Yeah.
Zymote might help. I mean, if you also check and you know in advance that there is some oxidation issues or some DNA
Mm-hmm.
fragmentation issues, then Zymote has more clear evidence behind it.
Mm-hmm.
Take out the sperm factor, okay, because this is important as well.
Yeah.
Things are difficult in the age of 47, as we said before, but you do
Mm.
have at least some good ovarian reserve for your age.
Yeah.
If you are not thinking of egg donation and treatments like that, you can keep trying,
Mm.
knowing that the chances are low because of your age group, but you never know.
Mm. And yeah, particularly, I suppose, if it's her first cycle, because that is a good number of eggs. So there's still scope, still scope for trying. This is another one here. Menstrual cycle was late in March and this month since an unsuccessful transfer in February. So I'm in the waiting period. How long until it should normalize again, usually? So, you know, your period getting back to normal after having gone through a transfer cycle.
Yeah, I mean, to have a couple of months of changing your hormonal status and have a bit of changes in your periods is normal.
Normal.
Now, it depends on your age group, how old you are, what is the situation. I mean, I wouldn't
Mm-hmm.
delay the next, IVF or anything
Mm-hmm.
for too long if, depending on your age and depending on your ovarian reserve. I mean, there are ways of scheduling as well if your cycle is irregular, of taking hormones in order to schedule it and go through the process of a new, I don't know, embryo transfer or
Exactly.
stimulation or whatever you.
Yeah, it can take a while, and also the stress and everything of it.
Hmm,
So, you know, don't be
yeah.
too hard on yourself. This person notes, I've gone through 3 rounds. I always get day 3 embryos, never day 5. What to do? 40 years old, and there's no PGT testing in my country. That's rough.
Yeah, I
Mm.
mean, when we say that day 3 embryos, never day 5, it means
Mm.
that you leave the embryos to grow to day 5 and they don't even
Yeah,
reach day 5, or
yeah,
you prefer to transfer the embryos on day 3? I mean,
yeah.
if
It sounds like the former, I'm guessing, from the way she asked this.
Yeah. I
Yeah.
mean, in this case, to be honest with you, I mean, we have a policy in Athens with our laboratory of leaving the embryos to grow to day 5. We
Mm-hmm.
trust the laboratory. We know that if an embryo has the potential to grow to day 5 in our lab, will grow.
Mm-hmm.
So it's a matter of selection as well of the strongest
Right.
embryos to put back. So if this is the case. Now, if the
Mm.
embryos you leave them to grow to day 5 and they don't reach day 5, it's very important to check very well the sperm as well, because the sperm factor goes many times after the third day
Mm-hmm.
inside the embryo. So many times, if you have a poor conversion rate between day 3 and day 5, it might be related to the sperm as well.
Mm-hmm.
And we say, depending on that, you carry on. Yeah.
It is a confusing one, isn't it, though, for people? Because it kind of depends on the clinic you're seeing, you know, their policies or protocols for day 3 versus day 5. Because I see huge differences between what people are advised. And so I suppose it's generally speaking the rule that if it's happened before, if there's very few, or maybe if there is concern, the embryologist doesn't think they're looking great and they probably won't make it to day 5, then they might decide that they want to transfer or freeze them at that point. But on the flip side, it is true that a day 5, at least, or potentially day 6, is going to be more robust. So that's kind of the goal, isn't it? Is what
Yeah.
you're looking for. Yeah.
I mean, to my thinking, you don't leave embryos to grow to day 5 either because
Mm-hmm.
you don't trust your lab or because
Mm-hmm.
you don't want to stay without embryos.
Mm-hmm.
Because it's difficult sometimes to explain that it's a bit disappointing to not
Yes.
having embryos.
Mm-hmm.
But on the other hand, it's equally disappointing of transferring embryos of day 3 and having a negative test, and at the same time
Exactly.
going through the procedure of the embryo transfer, which
Yeah.
is not the easiest one.
Yeah.
So, at least in Athens, we
Absolutely.
prefer to leave the embryos on day 5. We know that if they have the potential
Mm-hmm.
of reaching day 5, they will reach day 5. And
Mm-hmm.
also, we prefer to do frozen transfers unless it's everything straightforward and the person doesn't want to do PGTA, because with the vitrification that we use for freezing, we have equal or even better chances of success with frozen transfers. And we wait for the hormones to cool down, the implantation window to be stable and as we want it, and we transfer the embryos on a later stage in most of the cases. Okay.
I think that's so important what you said there, because again, even if somebody doesn't do PGTA and they're just choosing to freeze or being advised to freeze, I think mentally people, I joke with people sometimes that, they would rather eat a fresh dinner rather than something out of the freezer. So people mentally think that a frozen blastocyst couldn't be as good as fresh. But of course, with the type of freezing methods, with the vitrification, it's so different now to how it was even 8 or 10 years ago. So it's just for people to understand that it can really be to your advantage in many cases. So yeah, thank you for raising that. Now this one is quite a long question, so I'll leave it up for a while so you can read it all. 42 years old, 1 child, 4 years old, conceived non-assisted. 1 unsuccessful IVF in February, had 11 follicles, 3 embryos at day 3, but 2 of them collapsed. 1 egg, 3 AB implanted fresh, or I presume 1 embryo, but in the uterus was a polyp and the AMH 7.9. FSH, there's all the test results, FSH 6.7, LH 2.3. And yeah, so I plan on doing IVF, but expect more eggs and doing PGTA. Froze them, then remove the polyp to transfer the embryo into a good uterus. Fair enough. I want to create the embryos as fast as I can, because she is 42, and then focus for 2 to 3 months to lose more weight, because I did react enough to the medication, or I didn't, I think, react enough to the medication even while being overweight. And in my opinion, I should lose more weight to have a safer pregnancy than anything else. So in your opinion, should I follow as planned and do IVF in the next month and then lose weight before transferring, or should I postpone everything and just take 6 months to lose weight? So I think the question is, will she get better outcome with a retrieval cycle if she takes 6 months off to lose weight, bearing in mind she's 42, or should she do another retrieval and then lose weight before the FET?
Yeah, it's a difficult question, actually, and a nice question. Well, I don't know what obesity we are talking about, if we are talking about a BMI in the extreme levels or not, because we need to take into consideration the risks as well.
Yes.
But I mean, if it is not something very extreme, to be honest with you, I wouldn't delay. Protocols of IVF, when we have increased BMI, need to take into consideration the BMI. They are very tricky protocols.
Yes.
They are sometimes difficult egg collections as well. They need to be done by experienced reproductive medicine doctors. The medication might need to be on higher doses. This woman has a good antral follicular count. To get more eggs might give her the one healthy one that she will achieve to transfer later on. If we are talking about extreme weight that would put her into risks of going through the whole process, with the right protocol, with the right adjustments and everything, I would proceed into about taking the eggs, getting some more eggs, leave them to day 5, see first of all if we have this embryo that it's the precious one, the healthy one, and then she has as much time as she wants to lose the weight and deal with everything else so that she can transfer this embryo under the best circumstances. Now, if we are talking about extreme levels of BMI, we need to take into consideration health risks and things like that as well.
Always, it's always individualized, but yeah, I'd agree. 6 months is quite a long time at that age. Maybe the compromise might be a few months, if really that is a concern and if it will impact the protocol. But yeah, I'd absolutely agree with that.
And it's difficult to lose the weight as well. It's not always easy, and you don't know how much weight you will lose.
And safety of losing weight as well, because I've seen, well, we won't start that kind of worms with the Ozempic conversation, but I've seen many cases with that, and you have to lose weight safely and with monitoring and everything, not doing crash diets just for the sake of it. That's really important. So another one here, let's bring up this one. So on the baseline scan, I had 9 follicles showing. I just had a cycle cancelled as only 3 follicles were showing up after taking stimulation meds on a long protocol. how many cycles can it take to find the correct dose of medication that will respond to with stimulation? That's a great question.
Yes. Listen, 9. I don't know the age. I don't know.
We'll guess over 40, given the
Yeah.
topic. We'll assume.
Yes, I don't know exactly the AMH because sometimes it plays a reason, a role as well. 9 follicles, it's not a bad number if it is associated with fair AMH as well. Should be able to get some stimulation and some eggs with this number of follicles. I don't know the doses that she started on. I don't like the long protocol in women more than 40, to be honest with you, because
just going to
sometimes,
say,
because sometimes it down-regulates the ovaries and it makes it more difficult to stimulate, or makes it more higher dose in order to stimulate. So I would go on another protocol. And the question on this number of follicles on a high dose, a low dose, it's a very difficult question. It depends on many different factors. With this number of follicles, most probably I might try an antagonist of high dose in order to get as many eggs as possible.
If you could explain that to people a little bit, just who maybe are just totally confused about the endless different protocols, because I think that's such an important point, because I've seen that problem for people, the difference with the long protocol versus obviously shorter Agnes style, so that people can understand why that might be problematic for the numbers of eggs they're getting.
I mean, every protocol has advantages and disadvantages. I mean, the antagonist protocol, the short protocol, it means that we start in the beginning of the cycle, or sometimes even in the luteal phase of the cycle, because we are doing that as well if the follicular recruitment is better in the second stage of the cycle. We give gonadotrophins, medication like Gonalef, Menopur, Meriofert, all this medication. We try to stimulate the ovaries, and at some point when the follicles increase in size, we give an antagonist, a medication which is called either orgalutran or cetrotide, to just prevent the ovulation. And this is one protocol. And the long protocol, it means that we are down-regulating first the ovaries with some injections that are called GnRH agonists. The problem with this has some advantages as well, but the problem is that in poor responders, in women with poor ovarian reserve, they might over-suppress the ovaries and make it more difficult to stimulate the ovaries later on. So, I mean, usually, especially in the era of vitrification and freezing, that you are not interested in the implantation window, I prefer starting straight away with the gonadotrophins on a short protocol in poor ovarian responders.
Yeah, essentially, you're not quieting everything down in order to try and wake it back up again. You're just starting from go. I think that's important for people to understand, because otherwise people blame themselves when it might actually just be the protocol that they were put on. So definitely query that, I'd say. And we'll have to be finishing up soon, so I'll just run to this question. Apologies that we can't get to everybody. 43 years old, had miscarriage last year in July after getting pregnant naturally, non-assisted, had first round of IVF in February, got 7 eggs, 5 fertilized, 2 embryos transferred on day 5, but they were categorized as 4cc. A failed transfer, AMH of 3.09. Is there another round likely to achieve a similar result? Because the clinic has advised egg donation.
Listen, you need to know that your chances are low with own eggs. In the age of 43, with an AMH which is significantly low, the chances are fairly low. Also, you need to know that through your IVF cycle, you achieved an embryo which is not good grading. It's not good quality. It reached day 5, which is good in a way, but it was not very good in the grading, the way that it looked in the microscope. Egg donation would give you chances of 71%. The answer is that if you are psychologically ready to jump to the egg donation, jump to the egg donation, because most probably you will get pregnant. With IVF, with own eggs, most probably you will not get pregnant. Okay, but it's a completely personal decision. If you want to try it again, if you want to try a different laboratory, a different protocol, get some more eggs, see if the same thing will happen again or not, if the quality will be the same or not, investigate a bit more the sperm, prepare maybe a bit better, choose a different protocol, you can give it a try again, knowing now, though, that your chances are low, and being realistic about your chances so that you don't get disappointed. But you can give it a second chance if you want, and if you are not ready to jump to egg donation.
Yeah, so important, because it is a tough decision. And I just want to say thank you so much. I'm just scrolling through the endless questions here. I'm so sorry that we can't get through all of them. But as you can see, this is a big topic. There are many factors to consider. So while obviously the title is Conceiving Over 40, and we know it's referring to the woman being over 40, as Harry has pointed out, there are so many different variables to consider with regard to the sperm and the internal environment and the protocol you're on, and what clinic you're working with and what they're likely to test or not test. So just be very mindful of informing yourself, I think, is the key thing. So would you have, Dr. Harry, any parting words of wisdom or key thoughts for somebody over 40 who is concerned about their likely odds with fertility treatment?
Jump to IVF treatment sooner than later. Be proactive. Time plays a role, and it's getting worse and worse every year that goes after 40. Make your choices correctly when you choose a laboratory, a doctor, a clinic. Persist, because sometimes if you persist, you might win. But be realistic.
Yeah, that's great advice. I'd second everything you said there, because it is a tough journey, and at every stage you're going to have to take a step back and review where you're at so that you can make that decision. So that's absolutely appropriate. So thank you, as always, Dr. Harry. That was lovely to be able to go through all that with you. And I really hope that proves helpful to people who tuned in, and indeed those who couldn't tune in live and are going to watch the recording, because this will be available afterwards to you. Big thank you to the European Fertility Society and My IVF Answers, without whom you wouldn't be watching this right now. And as always, if any of you are really struggling and you need additional support, please be mindful that you can reach out to myself and Dr. Harry. So where would people be contacting you? What would be the best place? Over email or Instagram? What would be preferred?
Well, email through our website, through Instagram, Facebook. We are in all the social media, but the best way would be to just log into our website, and they can ask for a phone call, where they can send an email, they can go through the chatbots.
Yeah.
Plenty of ways.
I would highly recommend doing so. Having seen Dr. Harry at work at the fertility show in Dublin back at the start of March, you'd be definitely well advised to do that. Take advantage. And for myself, over DMs on Instagram, because I can answer with a voice note much faster than typing an email. So that's usually how I'm speaking to people, because you're definitely not going through this alone. So thank you so much, Dr. Harry. I really appreciate you giving your time and such helpful answers to people. And I look forward to tuning in with you again very soon, and seeing you all again for the next webinar. So have a great evening, everybody.
Thank you very much, Jessica, and good luck to everybody with the treatments.
Take care. Thank you.